National Skills for Care update for you. So there's quite a lot to get through. So without any further ado, hopefully you can see these slides that I'm sharing. So bear with me 1 second. So firstly, our Moving Up programme. So this is our leadership programme aimed at Black, Asian and minority ethnic leaders who want to take the next step in their learning and development journey. So it's just open for registration now. So have a look on our website for details, and everything's on the website on the Moving Up programme. So do have a look if it's something you're interested in. It's a really good programme. It's being delivered by a combination of online learning, so a blended learning approach, so self-learning and live online sessions. Workforce shaping, commissioning, planning and transformation. So in the past we've had lots of information on this in different places on our website, but we've created a new web area which sort of links all these categories together in one place. So there's lots of information there which is quite useful for managers or owners or nominated individuals, particularly around sort of workforce planning. So if you're looking at your current or your future workforce needs, there's some really useful resources on these pages that can help you on there. So do check it out. New person-centred and community-based working guide. So this has just come out in July, so literally just gone live, and it's a new person-centred and community-based working resource. So there's information on what community-based working is, why it's important and how to do it, and it can help you sort of move your focus on from focusing what's on wrong to what's strong, and using strength-based approach within your setting. It's free to download. It's got lots of well, actually it's an interactive PDF, so there's lots of stories and videos and sort of learning exercises on there. So yeah, it's quite a useful resource that's just come out. We have the size and structure data through our workforce intelligence team. So the latest information has just come out for the adult social sector workforce in England. So we release the England data, and then later there'll be regional, and later we bring out some data specifically for Norfolk. We do have some interactive data visualizations that are available all year round though, and as part of them there's some really useful data in there. So there's some that link specifically with COVID. So there's stuff around staff levels, vacancies, occupancy rates, levels of sickness as well. So and you can access them sort of whenever you need them. So we have done a lot of work around making our data a bit more accessible and easy to use and available. So I would have a look if that's something that you're interested in. We've recently launched an employer's guide to deployment of qualified registered nursing associates in social care settings. So this guide really helps to sort of strengthen your understanding of how the nursing associate role can fit into your organisation, but also it looks at what the relationship between a nursing associate and a registered nurse is, and what the differences are in their responsibilities. It looks at the regulatory frameworks as well, so you understand sort of how the role fits in and how you can use it in different settings. So yeah, that's been launched recently and it is a useful guide. I mean, the nursing associate role has been around for a little while, but it's still a relatively new role that people are still learning about. So if it is something that you're interested in, this guide is a great sort of first port of call, I would say. There's a new award which some of you might be aware of. So the Chief Nurse for Adult Social Care, Professor Deborah Sturdy, has outlined her commitment to recognise the outstanding contribution made by social care workers and nurses in England. So there's gold and silver awards that recognise outstanding contribution to adult social care, and it sort of aims to bring recognition of our workforce in line with that of the NHS workforce. So you can nominate people throughout the year, and we're really keen actually for social care to start nominating people for awards so that we can show the amazing contribution that we all make in this sector. It's not just limited to registered nurses, it's across all care settings, not only care homes. So if you want to find out more, go to the gov.uk website, so the links there on these slides. I will share these slides with Pete afterwards as well, so you'll be able to get hold of the links if you want. Yeah, I really do recommend that you put in a nomination if you've got anyone in your workforce who should be recognised. A lot of you might have seen this graphic already. I just wanted to include it because it's got the timescales around mandatory COVID-19 vaccination for care home workers. So that's been put into Lords. It went through the House of Lords the other week. So the 16-week grace period has started. That started on the 22nd of July. There's some key dates here. So the 16th of September is the last date for care home workers to have their first dose of the vaccine, so they're fully vaccinated in time for the regulations to come into force, and the 11th of November is when the regulations come into force. There's going to be some information coming on the Skills for Care website, sort of kind of like learn from others, how people have been encouraging their staff to take up vaccinations, which might help. I'm sure there's lots that's happening specifically in Norfolk as well, and I'd imagine that Norfolk Care and Support will be the first port of call for that information. Throughout the COVID-19 pandemic, we've been putting on webinars for registered managers. They're just sort of 30 minutes long. They're all recorded, so you can look at them online whenever suits you. These continue, and we've built up quite a range actually of really useful webinars that are on, and there's some of the topics on this slide here. We're still recording them. So recently we've done some around good governance and the benefits of board and trustee support. There's one around managing complaints, and there's a new one looking at medicines from a regulatory perspective, which was with CQC. We've got other ones coming up as well. There's one focusing on supervision, which is soon, I think, and then there's one which I'm involved with, which is focused on well-being and recovery and moving on from the pandemic. That's on the 23rd of September, and you can register now. It'll be great to have some Norfolk faces and names there, so if you are free, please do join in. I'll really appreciate it. To support the webinars, we've created some bite-sized resources, so we're aware that our resources are quite thorough and some of them can be quite sizable, so we've really tried to pick out some of the key elements of them, like the top tips and any templates and stuff, to create these bite-sized resources. So we've created them on those topics that are on the slide there, and we've still continuing to do so. So there's one which has just come out around wellbeing, for example. So they're all available and they're linked to the registered manager webinars, so you can find them on our webinar page. Some of you might be aware that we've got a Care Exchange podcast. So two of my colleagues, Ali and Pia, who are locality managers like me, have interviews with managers from different care settings across the country, and they're an interesting peek into sort of the journeys that other managers have been on. And if you are into care podcasts, then I definitely recommend a like and a follow. And if you're not into podcasts, then give it a go. It might get you into them. Deputy manager networks. So we've been running networks across the country. We've been piloting them really for a little while. So we had a network in the Cambridge, Peterborough area, which we then opened up to Norfolk a little while ago, and now we're opening it up to the whole of the eastern region. So these networks are specifically for deputy managers, team leaders and assistant managers, and they are facilitated by a locality manager, and they tend to focus on a particular theme. So we had one recently around well-being. I think we've got one coming up which is around partnership working and communication, and they're an opportunity for deputy managers to come together, sort of learn from each other, do a bit of peer support and networking. They're all done over Zoom and online, and actually that works quite well for deputies who often don't get the opportunity to get out and about quite as much, so they will remain online. And yeah, if you do have any deputies or team leaders or assistant managers, have a look, because it's probably worth you sort of pointing them in the direction. It's a really useful group for this group of people. Some of you might know that we're the membership organisation for registered managers, so we have a membership offer, and it's through this membership that we support managers to develop best practice and knowledge, keep up to date with development and share ideas. The membership costs £35 a year, and it's got a number of benefits. So you get a copy of the Social Care Manager's Handbook, there's monthly newsletters, there's you get access to other sort of discounts and resources, learning and development opportunities, that type of thing. So if you're not a member already, it is worth you having a look at if you are a registered manager. There are some perks, and I've just got some new perks that have come out recently which I just wanted to share with you. So firstly, we've got a exclusive e-learning course from NAPA, so the National Activity Providers Association. They've launched a new e-learning course called Activity and Engagement Leading the Way, and it's being offered free of charge to all registered manager members. So it looks to increase the awareness and importance of activity provision in care, and it helps registered managers to provide more personalised care and activities. So if you are already a registered manager member, you can go into your membership portal and there'll be details of the course there. Another example is we've just linked up with Quality Compliance Systems, QCS. And we've got a new resource for registered manager members. So our members will be able to access their resources throughout the year, starting this month, around preparing your service for winter pressures. So again, you can access that through your membership portal on the account. So we do try and sort of add different perks to being membership throughout the year, so it is worth looking into. CQC provider support. So I'm aware that the CQC is moving on from its sort of transitional monitoring approach to a monthly approach. So I thought I'd remind you that we have got some useful support available. So we've got recommendations for CQC provider guide, which has recently been refreshed, and it's got signposts to lots of different skills for care support that can help in different elements of inspection. And we've also got the delivering good and outstanding guide. So that's got best practice and sort of key characteristics of good and outstanding care under each of the key areas of inspection. So there's a lot of information on our website, which is a great point of call, so I would recommend you having a look at that. Also, locality managers like me are sort of here to point you in the right direction of around this, and we can help individually with sort of preparing for inspection, that type of thing. So do get in touch if that's something you'd be interested in finding out more about. So wellbeing, a couple of bits on wellbeing. We've got a wellbeing resource finder. So this aims to be an easy tool to help you find trusted resources to help your own wellbeing and that of others in your team. So you can you search for different types of resources, whether that's self-help or support for teams, and it pulls up all the sort of resources that are on the finder. There's quite a lot on there now. And it's just a really useful place to bring everything together. We're aware there's a lot out there around the focus of wellbeing, so this aims to sort of bring all those trusted resources into one place. And then also on here, the Bite-Side Wellbeing Guide, as I mentioned before, has recently come out. We've also got a sort of sector stories around wellbeing, learn from others sector section on our website. So on here you'll find good practice stories and practical tips from others services. Sorry, that's my dog barking in the background. You'll have to excuse it, it's probably the postman. So yeah, hopefully that's completely Maggie shush. So yeah, there's lots of stories there from other providers who have done something innovative or slightly different to help the well-being of their own well-being or that of their team. So there's some stories around creating staff bubbles. There's some videos that are just about to go on actually, which are support from wellbeing hubs from different part of the country, and they had a clinical psychologist go into sort of care homes and do one-on-one sort of reflective practice with some of the workers, and some really interesting stuff that came out of that. So do have a look on that section of our website. Our advice line continues to be open, so if you want any advice on anything to do with Skills for Care offer, or also, I mean, it was originally created for the COVID-19 pandemic, so there's still offer advice around all the guidance and things that are coming out of C19, so that's the email and the phone number. Rapid induction training, so this is available again, so it's there for it's a fully funded induction program to help new workers perform their duties safely. So we've got a lot of information on here. It covers the main knowledge elements of the care certificates. It's delivered through our 12 endorsed providers, so details are on our website there. Learning from events, I think I spoke about this last time, but it's a short digital module that's available to help you with learning reviews. So it's for managers and leaders in all care settings, and actually registered nurses, deputy managers might find it useful as well. It's just a 35-minute module which goes through what a learning review is, and this PACE model, which is what we're advocating for it. It's had really good feedback actually, and you can get WDF funding towards it as well, so I would recommend you having a look at it. We've got other digital learning for managers, so there's 11 modules available on leadership, succession planning and developing future talent. Again, there's WDF available. When we launch WDF, there will be funding available towards these learning modules for managers. So they're really useful for to keep your learning development process going on as managers. There's the new care certificate assessors e-learning course. So this was created in partnership with HEE, and it's been designed to support existing care certificates assessors to refresh their skills, but also to those new to assessing. Again, there's WDF attached to it, and it's 2 25-minute sessions which give an overview of assessment principles and then assessing the care certificate in the workplace. Funded recruitment and development initiatives. There's quite a lot of different funding streams available that help to recruit or development new workers. Sometimes it was difficult to sort of track down the information on what was available, so we've created a new website which aims to put all that information in one place. So it's just in funded recruitment, so do have a look if it's something you're interested in, and we'll keep that up to date as well as if the government bring out more initiatives and that type of thing. That'll be added on there. The Digital Eagles, so Barclays have an e-learning platform called Digital Wings, which can be accessed by all adult social care organisations, and it offers a range of resources really, where adult social care staff can complete bite-sized training. So they've got information on staying safe online, socialising on social media, making your business digital, all that type of thing. So they're freely available. You can register and then use the code EFCAR, and so yeah, it's just a useful result that we've been sort of promoting because it's there, and it is quite useful. And then finally on my whistle top tour is Every Action Counts. So the Department of Health and Social Care have adapted the Every Action Counts suite of resources to support adult social care providers achieve excellence in infection prevention and control. So there's like a toolkit on there which has lots of posters, digital key cards, hints and tips, which looks quite useful. I hadn't seen much about it until recently, actually, so I thought I'd included it in here as others might not have seen it either. But have a look. We've got some information about it on our website and also on the DHSC website as well. So that's my super speedy presentation. I'm conscious that I wasn't able to see the chat, so I don't know if there's any questions or anything, but please do feel free to ask questions. I will put my email in the chat as well. And then just finally, before I finish, if that's okay, Christine, just so people are aware, I'm pregnant again, so I'll be going off on maternity leave from sort of late October, November time. My colleague Karen Andrews will be covering for Norfolk while I'm away again, so she did that last time, which wasn't that long ago really. So some of you hopefully will know Karen. She's lovely and just a fountain of knowledge, so she'll be great to support you. And yeah, that's it for me, unless there's any questions.
We haven't got any questions at the moment, Fran, in here. There was a couple that were picked up earlier, which were about whether mandatory vaccinations apply to home care or supported living. Just for clarification, this is mandatory vaccinations for care homes only, and that covers all care homes. So that's whatever age, working age adults and older people, but it is care homes only. However, the government are going to undertake a consultation. We haven't got the date of when that's going to be, but a similar consultation to what happened with care homes for the wider health and social care workforce. So that will include all workforce. But again, we don't know the date, and obviously the outcome of that is still yet to be decided. So nothing at the moment.
Yeah.
And we have lots of congratulations for you, Fran.
Oh, thank you.
Which is just lovely news, and it's always very nice to have something very uplifting in these very trying times, shall we say. So,
yes. Oh, well, thank you ever so much.
Yes, lovely. But has anybody got any questions for Fran? Because this, can I just check, Fran? Is it okay for that to go out, the presentation?
Yeah, of course. I'll send it over to Pete or Megan or both of you, and then yeah, that can go out to everyone, and then obviously there'll be the recording as well. So, and I will just put my email address in the chat box. I'm aware that I flew through that as per usual, so yeah.
Yep.
Okay, thank you. I've got a blank screen, so this is going to be entertaining. Cool. So hello and welcome everyone. My bit of the presentation and jump in the queue is to give an update around PAMMS. So just an update around progress and provide a feedback and emerging themes. I still can't see my presentation, so I'm not sure when I need to click onto the next slide or what slide you're currently seeing at the moment. I've got the spinning a wheel of.
We can see slide 1 at the moment, Stephen.
Okay. Yeah, I can see it as well now. Perfect. So to start again. So I'm here to give an update around the progress and feedback to date from PAMMS that we've been conducting, and kind of an overview of emerging themes as well that we've found. The presentation is not as in-depth as Fran's or as many slides of Fran's, so but it's a more high-level overview. So kind of to give progress then, so to date, so in April 2021, this year, Norfolk County Council started going back to business as usual as part of our recovery plan. So we started conducting PAMMS again. So PAMMS was put on hold in March last year when the pandemic hit, but in April this year, we started to go back, part of our recovery plan, to go back as business as usual. So we started conducting PAMMS again, so actually crossing threshold and conducting the audit. Prior to kind of April, we were doing things virtually, and there is a limit to how we can support and what we can see doing things virtually. So PAMMS crossing threshold has been extremely beneficial to us as a team. But yeah, to date, we've done 36. So since April, we've done 36 PAMMS, crossing thresholds in different settings. So we're going full steam ahead. And the kind of the feedback so far, to kind of give you an overview as well around kind of the percentages. So to date, from the ones that we've completed and where we've done the draft report, and where we've published the report, we've got it's a mixture of poor, RI, and good services we've seen. To kind of give percentage next to these figures, we've so far to date we've seen 16% PAMMS come out as poor, 57% as RI, so the main bulk, but we've also seen good practice where we've seen 27% come out as good. So it's a mixture, but the majority of PAMMS that we have conducted have come out as requires improvement, and I'll go into kind of the emerging themes to kind of give our feedback to what we've seen so far and how we can support the market to move to good and higher. To kind of to give feedback. To give feedback of what we've seen so far. So the feedback has been still hear some ruffling in the background, Tim. I'm just going to pop you. Okay, thank you. Yeah, so feedback to date so far has been extremely positive, so very well received from the market. PAMMS has been, and kind of give a few bullet points. So for an average rating of 4.91 out of 5 are finding out this is extremely helpful. And an average of 5 out of 5 are finding out quality monitoring officers outstanding in the work they're conducting. So that's extremely positive feedback. We were gathering the feedback through Microsoft Teams questionnaire. So every time we've done a PAMMS visit, the QMO will email out a link for the providers to complete. So thank you to the providers that have been completing those links, because it's good intel for us to make sure that we are doing as we are saying. But the feedback so far has been extremely good. So thank you. But to kind of, I have put some examples in those bubbles, but I'm not going to read them out for you because the presentation will be shared. But kind of to take a few words out of it, so far you found the PAMMS very supportive and worthwhile, also informative, helpful, but also a critical eye, and you've appreciated the support given so far, pre-visit, post-visit, and during the visit as well. So in general, very happy with the feedback we've been receiving from providers. And again, thank you for completing those links. But it just shows you the value of PAMMS and actually crossing threshold and doing the audit. So we can of course be critical because that's what the PAMMS audit is. But at the same time, we also want to be helpful and support the market in becoming compliant or maintaining compliant. Some emerging themes. So what we've seen is these are kind of emerging themes from the PAMMS we've completed to date. One of them is around governance. So one thing that we are finding is not that it's checking the checker. So audits are being completed, but they're not being checked at a high level, which then does leave room for error. And also it's difficult to then evidence-based what from the audits, what the common themes were found, how those were evidenced, and how lessons were learned and how they were corrected. So it's just, I think, one of the things that we are finding is audits are being completed, but they're not being checked at a high level. So it's checking the checker, really. But governance is very important in the world that we live today, as we all know. The second kind of common theme is inconsistent use of MCA. So what we're finding is we're finding a pattern and a theme of providers going straight to best interest decisions and skipping the assessment of the MCA. Or the mental capacity assessment. So it is important that that assessment is there to obviously evidence, and whether it's a lack of understanding or whatever it might be, it'd be good to kind of get feedback from providers to see how we then can support us as a local authority. But that is definitely a theme that we're finding with MCAs. that step is being missed and it's going straight to best interest without kind of the reason why the best interest decision was made. The other kind of common theme is a lack of involvement of relatives and residents during care planning or other processes and reviews of assessments. And it's whilst verbally we're being told that's happening, and there's definitely some good practice there and good examples that verbally are being said. If it's not recorded, it doesn't exist. So it's just, I think, again, it's something that's been emerging throughout the PAMMS we've seen, is that we believe it's happening and we're being told it's happening, but there's no evidence to back off that's happening. So if it's just, I think, if it's just make sure that it's recorded, that is the environment that we live in, and that's something that we look for, the PAMMS auditors look for, but also that the governing body looks for. Then the communication feedback is kind of another theme that we've seen, where communication has been gathered through questionnaires, or from you say we did, or we did you said. It's again when there seems to be a lack of evidence of how that's then communicated back to relatives, back to residents, and back to staff as well. So communication is obviously crucial in the world that we live in, but it's a lack of the evidence behind it. So there is, like I said before, there's some absolutely very good practice out there, but I think that the kind of the biggest merging theme is just to make sure and to kind of to reiterate that the importance of recording and the importance of the governance behind the work that's been carried out there, because the care that we've seen on the ground for observations and stuff has been of very good standard. So I think it's just making sure that it's recorded, and you're highlighting the work that you're doing and not afraid to kind of shout that the work that you're doing and completing as well, and sharing that with ourselves, with CQC, but also with the relatives, residents, and the staff as well. So it's important to kind of to discuss the good practice. But yeah, these are the common themes of the PAMMS we've completed so far, and obviously our aim is to support the market. To, like I said, to maintain the compliance or become compliant, because we can be more supportive, and that's exactly what we're here for. But obviously, at the same time, we are there to be critical, and that's exactly what PAMMS is. But it's a support measure. And kind of my final point is just obviously to say thank you for the work that you're doing and the care that you are delivering through tough times, because of the pandemic, it's not business as usual. But I think as we are, as an NCC, we're going back to business as usual in the recovery plan. We will be continue to do the PAMMS. We will be continuing to go and crossing threshold and working with the market to make Norfolk outstanding. There's a lot of work that still needs to be done because the pandemic has had an effect. But they're quick, easy wins. And it comes down to making sure that things are being recorded, things and that the checker is being checked as well at a high level, and that then there's clear evidence of kind of what was picked up, the action plans, what was actioned, and how that was resolved. That the evidence part of it is crucial. And that was it for myself. It really was a high level overview. And as always, you can follow us on Twitter. And any questions you go around QA or the PAMMS process or quality assurance in general, I've put the main email box in there as well, which will then go to your allocated QMO. But yeah, in general, thank you for the work that you're doing, because it's very much appreciated during tough times. And it's just, again, to reiterate the importance of recording and the importance of checking the audits that are being conducted to make sure that actions are followed. And again, we're here to support. Obviously, PAMMS is an audit tool, and it's critical, or it's a critical support mechanism. But it's a bit like a school report. It's there to pick up some of the things that might not be happening. But of course, then it's also working with the providers to implement and to share best practice. And training around MCAs is exactly where I was thinking as well, Christine. So thank you for putting that in the chat as well. I think it might benefit the market. So that's an action for ourselves to kind of take away, put something in the diary to kind of to support in it, because that's definitely a theme that we're seeing throughout the PAMMS that we'll be conducting. That's it for myself.
Thank you so much. That's really helpful. It might be something that yourself and Tim and ourselves could look at around arranging some MCA training, Stephen, because we did some around safeguarding an MCA earlier this year, but maybe that's something we could work on together and create some sort of training for the sector.
Yeah, sounds good.
Okay, and Tim, we've got you back. Fingers crossed. I'm nervous for you, but we'll see. Is there anything before Tim comes in that anybody wants to ask Stephen? There was nothing in the chat box, Stephen, that I could see. Oh, here we are. Having said that, Rod's just put, can you explain how you think your actions will change post-lockdown?
Hi, Rod. In actions, do you mean the PAMMS process? Can I just clarify what was meant by actions?
Rod, are you able to come in? Yes, he says, yes.
So at the moment, obviously, we're doing PAMMS in because COVID is still very much amongst us. Obviously, we've done the final step of easing of lockdown, but COVID is the pandemic. We're still living in the world of COVID. Hasn't disappeared, and obviously we've got the potential the winter pressures coming as well. So we don't know what's around the corner. PAMMS are currently being conducted in a COVID safe environment, as safe as we can make it. So we've got risk assessments in place to ensure that we're doing whatever we can to mitigate any risk of us going out into different settings. And hopefully that's being shared with the providers pre the visit, the risk assessment, and how obviously we are doing it as safely as possible. But as it stands at the moment, we are sticking to this tact because we don't know what's around the corner. But I think actions around change post lockdown at the moment, we can continue how we've been conducting PAMMS. So we'll continue to stick to our risk assessment because we want to mitigate any risk as much as possible because the cases are still amongst us. The vaccinations has really helped, and we've seen really some positive outcomes of people being vaccinated. That's being really positive across the market. But we still want to mitigate any risk of us going out to loads of different settings whilst there is obviously still COVID amongst us, and it's not disappeared as of yet. So we're sticking to our risk assessment, which is being shared with providers before the visit, and that way we can mitigate any risk. So as the time stands, Rod, I hope that answers your question, but we're not changing our tact that we've been doing recently. So we'll continue to stick to what we've been doing to mitigate any risk around COVID-19.
Thank you, Stephen. Thank you. And I'm just now going to bring in Tim. So we've all got our fingers crossed. Welcome, Tim.
Hi, Christine. Is it okay? Oh, thanks, Fran. That I understood. Everybody was going, yeah, I got that. Great, thank you. I'm so pleased about that because it would have been really embarrassing if not. I'm showing my screen again. Please just let me know when you can see it. That'd be really helpful. Oh, great. Oh, great. And I can see you as well. Oh, everything's worked this time. Perfect. Okay. Christine, just tell me what time I need to wind up because now I don't know where I am.
10 past 11 is what we have.
Okay, fine. Okay, that's great. So for anybody that doesn't know me, that's me. My long job title I'm not going to say because it's actually longer than Christine's, and that's saying something. So what I'm going to take you through today is a bit of an update on a general quality overview, quality status in Norfolk, and one of the slides that I've prepared that takes us to the July figures. Really regrettably, these meetings always seem to be set up the day after CQC update their data, and I was up really late last night hoping that they would do it last night. They did it, must have been after I went to bed, so this morning I've recalculated all the data for the quality across Norfolk regulated settings. It's not vastly different actually. For Norfolk it's slightly worse than it was yesterday, so I haven't put new dates on the slide, but I can give you the position there, and then I'm going to go on to talk a little bit about and also get your feedback, I think, on our quality improvement and escalation policy. what that means for providers, what it means for the county council, and get a little bit of feedback from you, just at a very high level at this point, pending our circulation of the draft with a formal consultation. I'm going to say later this month. I've said that every month for the last 3 months. Lots of things have got in the way, but I'm fairly confident it's going to be a this month thing this month, particularly because structural changes in our team, which I can tell you about in a bit. So that's what I'm going to do. So in terms of the policy bit, I'll talk a bit about the policy bit first. As I said, from CQC's updated ratings last night or early this morning, our position overall as a county, I'd say, to use CQC terms, I think we require improvement. Now, most of the providers on the meeting today, you may find yourself in this place of requires improvement. It's one of those that's a really tricky one to get out of once you're in there. But part of what my team's there to do is to support you to get out of that requires improvement place. And to get into the good place, but more importantly to stay there. That's the really difficult thing. Climbing out of requires improvement isn't actually that difficult. Maintaining it is a challenge, I think. And when we look at the data going back over several years, providers that are going in and out of good and requires improvement, there's a big percentage of them in the county. More than 40% of providers in the county over the last 5 years are those that are going in and out of compliance. So that's what we really need to focus our attention on, and I'm going to show you a slide in a bit that you'll have seen before if you were with us in, I can't remember whether it was the Holiday Inn or the Mercure, in February of a year and a bit, more than a year ago, when we were all together. And I'll have showed you this slide, and if you remember back that far, it won't look that different, which won't come as a surprise to you, but we need to do some work on that together. And together is a neat segue into this bit. We need a policy to help us address that, because we need to work out how we work together. If you were at that meeting that we were at as a multidisciplinary group, we had CQC at that meeting, we had commissioners from the County Council at the meeting, we had a lot of providers in the meeting, we had North and Suffolk Care Support, there were loads of other people, the health colleagues were in that meeting, all looking at how, as a system, including providers, we work out how to make those quality improvements and keep them there. So it's important that we have a policy that draws that together, so that we've got a vehicle and a bit of a destination in mind, and how to get there. So although it's a policy that I'm drafting up on behalf of the council, we do need everybody's buy-in for it. So that's why we're doing a formal consultation. The other bit about a policy of this sort is that it makes us as a council accountable. We've got accountabilities that are set out in the Care Act to support providers, to ensure, in the words of the Care Act, a diverse and quality care market. So that's we've got a duty in law to do that. So this policy sets out how we're going to do it. The law says that we will. The policy says how we'll do it. We want to do that with you. So you can see what it is we're going to do, but also so that you can hold us accountable for it. There's people on this call, I know, that have held us accountable for what we do in law without there being a policy present. Really important that we have a policy so that we can be transparent about how we do stuff. Surprise, surprise, that is the next bit. As I've said, the law holds us to account, and so does our contract with providers. So for anybody that's recently looked at their contract, I don't suppose anybody has, you'll see there is a provision in there that makes it necessary for providers to, one, comply with the Health and Social Care Act, which obviously you have to do under your registration, and be compliant at all times is what that law says, but also be compliant within the terms of the contract, which means that if you depart from the terms of the contract and or the Health and Social Care Act by being non-compliant, then you're effectively breaching the contract. We want to be clear with you about what happens when that happens. Because part of my wider remit is to look at how to work with providers who really don't have the capacity to improve. I mention this every time we meet, because there are a number of providers, they're not represented at this meeting because they're the same providers that wouldn't really turn up to this kind of event and maybe not really that interested in improving really. But for those providers that either don't have the capacity or will to improve, then we don't need them in the market, and we've got a piece to do around that. Part of that is to be really clear with them at the outset and that could be any provider at any time, what we'll do if a provider reaches that place. So that's another thing that this policy. Another thing that we've been criticised for in the past, not so much recently, but it does rear its head from time to time, is that we're treating one provider more favourably than another. And mostly whenever we're critical of a way a provider delivers its service, providers say, do you know what, you're absolutely right. It's great to have your second eye on things because we missed that. And I wish I'd been around for Stephen's presentation because I haven't seen it, but I'm sure he would have touched on something like that in terms of the feedback that we get from providers. You know, on the whole, providers say, you know what, we've appreciated having your, you know, your independent eye. There's things that we missed here. We're going to try and put it right.
Tim, the noise has come back again. There's back feed now. It was going so well. Yeah.
Not as bad as it was. Oh, hang on. No,
is it gone? It's back again.
It's worse.
Yeah,
it's worse. I don't know what has changed.
No, it's sort of.
Sometimes if you keep talking, it will disappear.
Yeah. Try talking and let's see how it goes.
Hello. Am I back and clear?
No.
Or not?
No, it's still there, Sim. I'm so sorry. Is there any way you could take your headset out? Maybe it's that's causing the feedback issue?
Well, I mean, it doesn't normally, but I'll have a go. Close up of Tim here. Getting behind his monitor. Will I pull out the right plug? That's the question. If you pull out the wrong plug, then you lose the camera. I think I've got a state-of-the-art plug system here, where everything looks the same.
Yeah, there's building tension here.
Tell me, it's like which wire should I cut? It's one of those.
Tempted to not edit this out of the video when I post it, you know.
Yeah, do edit this out because it's, you know, it's really not good telly. It's not good telly. I think this is the one. Hello, can you still hear me?
We can, but the feedback is still there.
Well, can you hear me at all? Because I can't hear. I can. Oh, people are nodding. Well, I'll tell you what. If you're content to hear me like this, I'll do it. But I can't hear you at all.
It's certainly better than it was.
It is definitely better than it was.
Okay. I'll just carry on, and then I'll put my headphones back on after I've finished, so that I can then hear what the queries are. But then I'll go on mute. Okay. Let me just race through this bit quickly then, so we're not losing too much time. So Council has been criticised for applying rules differently to different providers, and providers sometimes compare themselves to another provider when we're making adverse remarks about quality in their service. They'll say, well, do you know what, this other provider is doing exactly the same thing, but you haven't done anything about that. And you know, that argument only goes so far, but I think it will assist that. It will assist our position and also the position of other providers if we make really clear what the rules are. So that's what this policy does as well. It makes clear what the rules are, so we can say we're operating to them, and then hopefully we can justify decision making a little more easily when we do that. Let me see if I can move this on. And then finally, something that all organisations need more of, and to get it right, we need to set out how our governance works. So when we do take decisions, whichever decisions they are, whether that's a decision to publish a report that providers are unhappy with, whether it's a decision to take high level action in terms of breaches of the contract, we need a formula for doing that, and we need an agreed sort of governance system so that we can say who signs decisions off, how do we deal with challenges to those, and also in terms of governance, how do we re-look at this policy. So once we put this policy into place, it's had agreement from all parties, we've formally consulted on it. What's the process by which we'll revise that from time to time when it's necessary? So all of those governance processes all set out in the policy as well. So I said I was going to give you an update on what's the picture in Norfolk from a quality perspective across the pieces, and that's the bit that relates to the ratings. 74% is where we're at with compliance at the moment. We're still at 74%, which is just slightly less by a decimal. So this morning, I think last night we were at about 74.8%. this morning it's 74.5% compliance. So we're talking there just in raw numbers of providers that are rated good or outstanding, as compared with those that are rated requires improvement or inadequate. So that's where that figure comes from. And there's an important point to make about that. Here's the pie chart that you'll have remembered from February. Doesn't look vastly different. Great that we've got that massive, great big cheese chunk of good there, because most providers that are sitting in that place have been in that place for, you know, since ratings began. That's most of them. That's most of you. So well done, and thanks for that, because whatever you're doing it right. Just keep doing it. But you know, the worrying bit is that little chunk of that good that keeps going in and out of the requires improvement, and the requires improvement is still a considerable chunk there. That's the one we need to do some work on, but the picture overall looks pretty much the same. These are the July figures, didn't have a chance to update them, but broadly the numbers are the same. The percentages have changed ever so slightly, just by decimals, but it's not been favourable. But there's a point I'd like to make here, and that's about how those ratings are impacted by the CQC's new inspection methodology. So CQC have consulted on, and now they've kind of agreed their way going forward of how they're going to prioritise inspections, I guess is what it's about really. It's focused on and determined by concerns that they get, you know, that they receive, both in terms of safeguarding, in terms of soft intelligence, complaints, and other information that's available to them, including information that's shared between the local authority under our joint information sharing agreements. So what that means, I suppose, for providers is that where providers are operating in a fairly safe way, where they may be rated good and have been consistently good, the likelihood of CQC coming back to inspect a service like that will be remote, compared to a service who perhaps raises concerns from time to time. So the frequency of inspections to such services will be greater. Now, one of the factors that CQC takes into account when assessing whether or not a provider should be prioritised for a further inspection is liaison with the local authority, and within that, what they feature really highly is actually the outcome of a PAMMS, because that wasn't the case 2 or 3 years ago, but now they've got some stability. PAMMS are a realistic indicator of providers' quality, and CQC very much will look at that. Now, there's a negative impact on that for providers who are rated non-compliant, either requires improvement or inadequate, because if as an authority we've conducted a PAMMS on your service, which has rated your service better than CQC did last time, that it will be an incentive for CQC to say, well, do you know what, that provider's got better, we're not going to invest time going back to inspect, which means that the negative rating will sit around on the public profile for longer as far as CQC ratings are concerned. What we're trying to do is give PAMMS, it'll never have an equal sort of status to CQC ratings, because one, PAMMS isn't used everywhere. It's used almost in all the local authorities in the east of England. It's not used across the country, so it's not a decent comparator for CQC, because of course they regulate everything and report on everything. But what we're trying to do is give it greater emphasis, at least in the eastern region, so that commissioning decisions, for example, so that we can put more information out into the public domain about your more compliant PAMMS rating, and also work out a way of working with CQC, which is something that I promised we would do in February 2019, ways of working more closely with CQC to get them to do a piece of work that will ratify our ratings from PAMMS, and they've been able to do that in some instances. So providers have said, look, we've been sitting on inadequate, you know we're not inadequate, NCC have come in, rated us good, and in limited circumstances CQC have gone back in to do an inspection to effectively ratify the PAMMS rating. Which has meant that the provider's ratings have been reflected adequately on the CQC's portal. So just to make you aware that we are acutely aware of that, we're acutely aware of the damaging effects that it can have where you've got a non-compliant CQC rating sitting around, both in terms of your business, but also in terms of staff morale. So I'm working closely with CQC to see what we can do to remedy that, and that's made more difficult, I have to say, really, by the more recent decision to switch their way of working. We understand their way of working; it makes good sense in terms of addressing the actual issues, but there is this negative impact for providers that have effectively old ratings hanging around. So that's the position in Norfolk, and guess what? guess where we sit in terms of the East of England. So out of the 11 authorities, even with the update this morning, and I did check central beds as well, just in the hope that they got worse than us, and regrettably they didn't. So we're both still sitting on 74%. So we're both still better. You know, sometimes that's the best you can hope for, that other authorities will actually perform worse than us just to get off that bottom rung. But actually, it's not the case. We broadly sit in this kind of place and have done for quite some time now. We're always sitting amongst the bottom 3 at least. But you can see that you know, the effects of the pandemic is not unique to Norfolk. So providers are saying, well, do you know what, my obviously quality's gone down. We've had a hell of a lot to deal with. But when you're looking at it across the piece in the East of England, obviously all providers have been in that position. So quality ratings are going to look broadly the same, not in terms of percentages, but in terms of looking across the 11 authorities, they kind of look like this. And the questions that are being asked of me and of others is, how come Norfolk, which sits adjacent to Suffolk, is at the opposite end of this table? And it's a really relevant question to ask. I mean, obviously it is a different authority, although bits of it overlap. So bits of the stuff that I do with Norfolk and Waveney with my NHS hat on obviously overlap into the northern bits of Suffolk, the Waveney bit. But actually it is a question we need to ask a bit more about. How is it that, you know, it's not to do with geography, I guess is the answer. It's not to do with geography, but what is it that Suffolk's doing that can't be replicated in Norfolk, for example? And our other adjacent authorities, Cambridge and Peterborough, I guess, also right on our border, but also at the other end of this table. Why do we think that is? Well, these are some questions. We haven't got the answer to them yet, but hopefully the policy is going to go some way to be able to realise what some of those answers are. So who's in scope for this policy that you haven't heard about yet, but you will do? Well, guess what? It's going to be you. So if you're a CQC registered provider on this meeting, and you will be, then it's going to apply to you, particularly if we commission with you. So if you hold an NCC contract and we purchase care from you, then this policy will apply to you. But it will also apply to some CQC registered services that we don't commission with, and there are very few of them, frankly. In terms of residential care, maybe just a small handful. You could probably count them on one hand, and actually they're mostly compliant. For the main part, they are compliant, but CQC, we don't. The Norfolk County Council doesn't commission with them, but we still have an obligation as a team under the Care Act to look at the way they provide a service. So this policy will apply to them, and also for the first time, we're going to make this policy apply to providers of day services, which of course aren't registered by CQC, but sometimes sit within a CQC registered service. So this policy will apply also to operators of day services, now called day opportunities. What's new? I suppose it's an obvious question because we've never had a policy before. So you could argue that everything in this policy is new. But there's another answer to that, and that's nothing's new, because as I've said, the way that my team has done its work, at least since 2018, and also a little bit before that, has not been completely without foundation. We do it because there's a duty under the Care Act to do what we do. We do it because providers that we work with, at least, so the commission providers, have a contract with the council. So our function is also to look at the operation of the operational conduct of the contract. So we do have these things which kind of underpin the work that we do. But because we don't have a policy, we haven't really set out how we do that. So arguably it's new, so everything's new, the policy, but arguably also nothing's new because we're doing it anyway. So when you see what's in this policy, it shouldn't come as a surprise to you. For any provider that's ever had a restriction on their service, for example, they know how it works. It's self-evident how it works, but this policy just sets out the self-evident. Okay. Now here's what it is. So I'm going to give you just the top lines of what's in it, because this is where the test comes in. Because I'm going to show you this slide and the next slide, which really pretty much tell you what's contained in the policy. And then on the third slide, I'm going to ask you to remember everything that's in the first two slides. Because then I'm going to pose you a challenge to say, what do you think's missing? Because this is the first opportunity really that I've had to share it with you at this high level. I've got the detail behind it, but so that you can tell us what you think might be missing, what you think ought to be in there. And if you've ever had a question of the way we operate in the last couple of years, then if it's not mentioned in these next 2 slides, then it's your opportunity to say, hang on, Tim, how come that's not in there? Because we've posed this question to you. We kind of hope that would appear in your policy as well. So first bit will just tell you who we are, where we sit within the council, and also our key functions. It will tell you also the bits that we don't do. We get plenty of questions from providers and others, more particularly from colleagues in other bits of the council, to say, hey, quality assurance team, as we used to be called, this is your bit, and actually it isn't. So sometimes the functions sit in other bits of the council, but we set that out really carefully about what we do and what we don't do, and also the things that we might do from time to time. Then talk about how we interact and engage with these other key bits of the council, some of whom you'll be very familiar with, others less so, but all important for you as providers, because they all perform a function that's critical to working with you and ensuring that we're working effectively with you and providing a service that the council wants to commission with you as well. So it also sets out some of those bits, particularly setting out in relation to safeguarding, the bits that we can do whilst there's a safeguarding investigation happening, the bits that safeguarding can effectively give to us to do as part of the safeguarding inquiry, and the bits that we definitely don't go anywhere near, because that is the role of safeguarding to do. It's important that we share with you that, because often we get questions about, hang on a minute, how come we still don't have the outcome to a very outstanding safeguarding? We get that a lot. It's actually not sitting with us, but we can explain how that works much more clearly in this policy that will help you understand the route to go if you've got queries. Also how we liaise with other key partners as well, including yourselves, but also you'll want to know how we work with CQC. We have an information sharing protocol, as I referred to earlier. It's important that you know how we work with them, because although they're not often seen as the helper in these equations, CQC, don't forget what they're set up to do. They're set up to improve the quality of services. So we'll set out clearly how we do that, and also how they should be doing their job. And we don't always get it right as a system. Sometimes CQC don't, but this will set out exactly how they're supposed to work with us all the time, and these other odd bods that we occasionally have to work with as well, including district councils in relation to environmental health and some health and safety matters that they're concerned with, and how we work with them and you. A bit that's often forgotten about, and a really key bit actually, is how we gatekeep to prevent providers that aren't any good coming into the market in the first place. As you know, CQC will register anything. So part of our function is to ensure that those bits of CQC that are registered don't come into our portfolio in terms of commissioning by playing a really important role at the point of tendering. And we've learned that through bitter experience sometimes, where we've not been involved in a tendering exercise, and providers that aren't any good are registered, come into the market, provide really poor care, and then disappear out of the market very, very quickly. We've got a couple of examples of those over really recent history as well. So we're going to make sure that we're right there at the beginning to ensure that doesn't happen, really for no other reason than that actually people receive really poor services from some of those providers who've no experience of doing it. I think it's a great thing to do during a pandemic. I'll set up a non-care agency. It all goes pear-shaped. We sometimes commission it. Very, very embarrassing. We need to be there right at the beginning to make sure that doesn't happen. This is the stuff we do all the time anyway. Don't need to talk through that really. This is the stuff Stephen's done. Don't need to talk through that really either. And then there's some other bits and pieces that we do as well. Sometimes working with Christine and Norca and other bits and pieces as well. So I just want to wrap that up in a single chapter, if you like, of the policy to tell you about some of the other stuff we get engaged with, particularly in relation to the health side of my team, because the quality improvement nurses do a lot in this place, always have done, will continue to do as well. We're just going to set out how that works as well. Here's the second slide. The next one's yours.
Sorry.
So here's some. So the policy will also set out this. We'll talk about what we do. When is that Christine saying time up, or
yeah,
is it time up?
It is,
yeah,
Tim.
Okay.
Are you able to wrap up?
I'm wrapping.
Lovely.
So there it is. So these are the other bits. These are the other bits that are in there. Hopefully they're self-explanatory, Some of them won't be, because you won't be familiar with the quality improvement notice or performance notice. Very few providers on this call will be, because these are the providers that won't turn up to this sort of meeting. But it will set out how we do these things as well. I think all that makes sense, doesn't it? Thank you, Christine. It does. Okay, so the bits that I really like to hear about are what you think might be missing. So in addition to asking questions at this point about anything that I've just said, which I'm happy to take, while I'm plugging my microphone back in, I'd really like just to consider these things. Is there anything you think is missing from those last couple of slides? Let us know about that. Particularly if you've had any questions during the course of the last couple of years about what we do, how we do it, how we come to the decisions that we have a little think about that. While I'm plugging in, Christine will fill.
Yes, I will. So is there anybody that wants to take on that first question? What's missing from the policy? Is there anything that you think is obvious that's missing from the policy? Whilst yeah, that's it. Tim's getting himself sorted. So it seemed to me very, very comprehensive, but is there anything that the providers out there, you as providers, think might be missing? You can put it in the chat box, you can put your hand up, you can come in. Let me just check the chat box if there's anybody typing. I am emailing Tim directly. So Steve Dorrington is oh, so that's fine. Okay. Again, if anybody thinks after this meeting there's something missing, we want to know how that's covered in this policy, then please email Tim. And if there's anything in advance of the formal consultation or any other parts of your engagement that you want to pick up with Tim, then email Tim or, you know, contact us and we'll pass it on to Tim. I think everybody's gone very shy, Tim, or maybe they're just, you know, looking at the information, trying to take it in, and they'll need a bit of time to reflect. And
Kristen, I have a question, please.
Oh, hello. Who is this?
Yeah, it's Alfred. I'm from Holmesley House.
Oh, welcome.
Yeah,
yes,
I just have a question to Tim. I know you mentioned about CQC not removing their rating for quite a while because of either the pandemic or whatever. But I think it's very damaging for them to be able, if they are going to be relying on the rating and leave it in the public domain, then they've got to do something or remove it completely from the public domain, because you can't leave a rating on the system for over 2-3 years and say, well, you are busy. It is not good for the providers. It is damaging, as you said, to other providers who are requiring improvement. And it's the council then relying on this outdated rating to come up and say maybe we still have X percentage that are still require improvement, because the protest would have moved on. It isn't fair for us. So can something be done about it? It's either they are relying on those rating or they move it away in this pandemic and then think about when they're going to bring it back in.
How's the noise?
It's okay, Tim. If it's going to be brief, I think it'd be okay.
Okay, so it's recognised that the delay is problematic if CQC don't come back to inspect. It was raised as part of the consultation that CQC did as part of their review of the way that they were going to operate. So it's flagged there. There is a requirement in law for CQC to publish a report for every inspection they do, which means that what they can't do is remove the most recent report. So that isn't an option for them, because that they then be contravening the law. But they recognise that it's a problem. We recognise it's a problem as far as having an outdated rating is concerned. However, that doesn't mean that an outdated rating for CQC will prohibit the council from making placements developed, and in fact we've got a policy that an internal policy at least, where social workers and our procurement team have been made aware that whilst a rating may be non-compliant for CQC, if a subsequent PAMMS has rated a provider more compliant or compliant, then we'll continue to place with that service. We'll obviously review it, but we will remove restrictions. For example, I'm quite happy to agree removing a restriction in relation to a provider that is rated CQC non-compliant, so long as we've a comprehensive PAMMS that justifies their decision to do so. So hopefully that won't then impact negatively in terms of providers' income, in terms of making admissions, freeing up beds for the market, which are very much required, and Susanne will come to talk about some of that in a little bit. So that's our best compromise at the moment, I think.
Thank you, Tim. And Aaron, can I just ask, have you had a PAMMS yet?
I'm Alfred.
Alfred, I'm so sorry.
Yes, I had a PAMMS yesterday. Okay. And well, we're waiting for the result. But as far as I'm concerned, yeah, we've been rated require improvement by a technicality which I found quite odd during the inspection, but I let it go because I just didn't want to argue with CQC. I know that the council have seen our care home, and they know that we have been performing quite well. I mean, during the pandemic, we haven't had an outbreak in this care home till now because of our processes in. But my main thing is that if you're going to use a system to rate, yes, the law says that, but if you're going to do, then you must do everything you can to go and inspect and try and remove it. The council doesn't look at it, but the public does. So, if you're going to be attracting, let's say, private residents, they're going to be looking at a rating which has been there for over 2-3 years. And as Tim is saying, if the PAMMS report is good, then you have another maybe 2-3 years, 6 years that the CQC is not going to be coming at all. It's simply not acceptable. They can't use it. If you're busy, then they have to do something about it. I don't accept that. That is unacceptable because it's a law. It's the law, but it is affecting providers. They've got to do something about it.
Thank you, Alfred. No, thank you very much, and completely understand your point. All that can be done is to put pressure on CQC to make sure that they're aware of what providers are saying, and particularly the impact on business. And wherever that can happen, I'm sure that we'll find a way to do that. It's not going to be the answer at the moment, but that's all we can do, is just to keep reminding CQC of the impact on providers. Thank you very much, Alfred. Thank you so much, Tim, and well done for overcoming all those feedback issues. That worked in the end. It worked very, very well. So thank you very much, Stephen, as well. Susanne, we're going to bring you in. We are very short of time, but if people want to stay on, are you able to stay on for another 10 minutes, Susanne, and we can finish at 22? Would that work for you?
Yeah, yes, that's absolutely fine.
Okay, Susanne, over to you then.
Thank you, and thanks very much, Tim and Stephen as well. Some really important updates there in terms of the work that's everyone's doing, but also just recognising that area for improvement. And I think just about all working together. And I mentioned earlier in the chat, please don't wait for a PAMMS or a CQC review to get in touch with us. If there are areas where you sort of feel actually we could do with some support here, more information, then do please contact us at any time. So what I was just going to do here is just to go through some of the things that are happening in the system at the moment. So it's a bit headlines, but hopefully if there's anything that you want further information on, we can then sort of take that way, get back to you. But say just to give some headlines of sort of state of play, I guess, at the moment with some of the areas in the system. So hopefully I can move that on. So just going to cover these particular areas. So firstly, just to mention, as part of the health and care bill that went through, there was also a proposal to align the boundaries of integrated care systems with local authority areas, and obviously Norfolk and Waveney was one of those which would have been affected. However, the Secretary of State's decision was to have no change, so we won't be seeing a Norfolk health system. We will keep with our Norfolk and Waveney system, which obviously, you know, we've been operating with for quite a long while now. And I think that's really helpful that we've got that clarity now going forward. I think there was some people were thinking that maybe it would go on the Norfolk lines, you know, originally, possibly with the new Secretary of State, there was a bit more doubt with that, but say it is a no change situation. So in relation to the integrated care systems, those technically come in on April 2022. We've already made quite a lot of changes in the Norfolk and Waveney system. Obviously, we did have the 5 CCGs. We've now got one single CCG. I personally think that's working a lot better, because it's just easier. It's just so much easier to work with one single clinical commissioning group, and actually also lots of the big strategies that we're working on, everyone's working on as a system as well, and you know, involving social care and the council as part of that, but also, you know, bringing in district councils. I think it's getting housing, it's much more part of those conversations, which I think is a really positive step. In terms of what we'll see different, I think it will still be a bit of a continuing but sort of bolstering as we go. There's still discussions about how within the integrated care system we work at a place level. The primary care networks involving our GPs, that's being strengthened, and I think that will continue to strengthen and develop, you know, as we develop the integrated care system. And there'll be decisions about what is commissioned at what level, and some things will be commissioned at that lower place level. But they say it's still discussions about how that actually happens. What I think will be good is that our programmes of work will have that local focus, but hopefully also working at scale across the whole system. So, you know, the aim will be to not get those postcode lotteries, and that actually we have a commonality across the system, but also recognise where there are, you know, local pinch points or local issues relating to different communities, and that will be the aim, to try to get that balanced right. And hopefully more opportunity to work, you know, with those connections at a local level, yeah, and with all of you. And I just wanted to then just sort of just give a quick update on the enhanced health, which originally was the enhanced health in care homes, but actually we're now looking at it as enhanced health and well-being across all care settings. So these continue to be sort of cross-system programmes. I think some have made progress during the pandemic, some have maybe sort of stalled a bit. But I think, you know, the emphasis there on trying to make sure we've got that real join up between health and our care provision, our social care provision, you know, across the system, you know, is so important. These are still the main programmes, so the enhanced primary and community care support, which some of you will no doubt have seen in action, and some may be, you know, still at a pilot stage, but looking at the sort of medicines optimization, the virtual home rounds, so working really closely with primary care, and also looking at how community pharmacists play into that as well. The multidisciplinary teams, and that's about trying to make sure we've got these, you know, real standards about how we operate. I think, you know, we'll all see areas for improvement there. that we need to do and need to develop across the system. Things like how we operate with 7 days discharge, and actually all the components, you know, the end-to-ends that really have to work there to actually make that work effectively and safely, as well. Thinking about the role of carers, and to make sure that we've got commonality across the board with that. And then there's projects around you know, falls prevention services, the I Stumble project, and looking as well about how we're using equipment to best effect in all areas of our services. Palliative and end of life, mental health and dementia care. So this is focusing on particular projects to support improvements in those areas, and again to try to make sure that we've got standards across that. And then we've got the social prescribing as well. And so you can read some of the things that we've got there. The focus going forward is areas for development is continuing with some of the work around the oral health access and inequalities in healthcare, looking at that proactive management around long-term conditions and how we're getting the connections between health and social care to really be able to support individuals. Mental health outreach as well, which, you know, is a really important area across residential homes. Trying to improve those links to housing, which I think there's been actually huge strides in that. That's an area I think which is really the pandemic brought into sharp focus, and I think that there's a lot more opportunity actually now, more join up, which is really good. And the data and IT and technology, which is really important to be able to make sure we're sharing that information as well. So I know we're running out of time, so I won't go through all of these, but these are the projects being scoped as well. And in terms of strategic direction, really looking across, as I say, making sure it's across the whole care sector now, that this isn't just focused on care homes, but also looking at how the primary care networks will really do what they'll really do now to develop that and work alongside providers. So I think some really exciting opportunities there to really develop as a whole system. So the other area I just wanted to touch on is discharge to assess. So this is a really, you know, it's a large scale redesign, and full implementation of this won't really be till October 22. There's a lot of work to get us where we need to be with a fully operational system here. Principles, I'm sure you're probably all aware of. The essential criteria is supporting people to be able to go home. That's the default, but obviously alternative pathways where they can't. It's free at the point of delivery, so there's no means testing for individuals, and they can access that care immediately following hospital. And it's also about making sure that the assessment is being done in a timely way, so that discharge is safe, but also that the follow-up is being done in a timely way as well. Support is generally seen as good practice between aiming for 4 weeks, but sort of 2 weeks is seen as the optimum. So the focus here is that we're getting that discharge right, but we've also got the right services, the right outreach, the right health services available as well post-discharge. And that's the bit that's going to take time to be able to get right, and that we've got the hubs right for discharge as well. It is critical that we're working together as a system to be able to get that right. And I think that's going to be, you know, really important in these coming months to look at the design. We've obviously sort of been working in this way through default through the pandemic and through the hospital discharge arrangements, but I think we've had to be doing that without a proper structure in place, and that's, yeah, I think we've all seen some of the issues that has thrown up but I guess it's also giving us an opportunity to learn as well. You know, what works well, what actually was really awful, what doesn't feel safe, what needs to be in place to make people feel confident around supporting people with maybe the level of acuity they've got following hospital discharge. And I think, you know, personally, it's recognising, making sure that we're commissioning those right services for that. And recognising that it won't be right in all instances for some people to be supported in the existing types of services that we've got. You know, that won't feel safe to people, and I know that's also some of the feedback that's come back, you know, from some of you who have been involved with that as well, that actually it can feel quite challenging, and also to make sure that we've got that contact and that ability to be able to work collaboratively with you know, clinicians as well during that period. So I say engagement over the coming months is going to be really critical to get that shared learning, support that development. I think the aim is that Home First hubs will be implemented at the back end of this year. We're also working with developing then that short-term offer. Initially, a lot of that has been done through looking at short-term beds through block provision. The aim going forward will be to really be able to create those short-term step up, step down type units where people need that bed-based support. Reablement ethos is going to be key for this, regardless of whether people go home or whether people need to have a short-term bed. And I think, yeah, one of the things will be about then how we are recognising what that short-term need is, alongside recognising what the long-term needs are for people, and that they have that choice about their long-term care provision, and we do that in a way that you know, doesn't feel rushed, that people can make those choices about the type of care they want. But it is recognising that, you know, that there's a sort of a different need at that point of discharge, and the sorts of support and types of care that we're going to need, and recognition that, you know, nationally the Home First model, you know, is the one that is being supported. It is looking at wraparound services for people within their home. You know, that doesn't mean that there isn't a need for residential and nursing, which we know we've got we've got shortages for enhanced residential care and for nursing care in Norfolk. So, you know, that's not something that is saying that we don't need that, but it is also recognising that there is going to be different models in place in the future. And obviously the digital solution, you know, is a key part of that. I think one thing I just wanted to share though is we've got you know, data now about really what's happened since we've been following a D2A type model. I don't think we should compare D2A that we've got now with where we want to be as a system, because as I say, this is a really large scale redesign that we need. But it is recognising that we have had much higher volume coming through hospital discharge during this period. Some of this will be because people aren't means tested, so everyone self-funders, everyone is coming through that route, but that doesn't account for all of it. But actually the pathways at the moment are pretty much proportionately the same. The percentage that we had people going into residential care, the percentage into home support is very similar to pre-pandemic. It's just much higher volumes that we're seeing coming through from a council commissioned perspective. So it's interesting to see. I think we all thought that might reduce, and it hasn't as yet. We're still seeing very steady high levels of volume, which is interesting. Maybe not what we expected to see, but that's certainly the state of play at the moment. Obviously that, you know, that could change, but we are seeing, you know, that's volume of people coming through, maybe with some of those lower level needs that need to go home, and how we get that safe support at home. And then we're probably seeing a much higher number of people with some of the enhanced needs as well. And I think, you know, it's recognising as a market how we respond to that. Given that D2A model, say, will be sort of quite a significant change for us in the way that we operate. I think that's all I really wanted to say. Just going back, I think the only other thing I just wanted to mention was the cost of care review. Thank you so much for those people who have responded. We are just going to extend the deadline for a week just to give others a chance. We've had, this is on the cost of care for older people, residential and nursing. We've had responses predominantly from larger providers. So if there are any of you out there that are smaller residential or nursing care homes for older people who are able to respond, that would be fantastic as well, just so we get a really broad sense, and say it's your opportunity to tell us how it really is. So any responses gratefully received. Thank you, Christine.
Thank you so much, Suzanne. That was really helpful, and I learnt today that Waveney is still with us, so that was something that I know we've been waiting to hear, so that's interesting. Just before we wrap up, are there any questions for Suzanne from anybody here? Because Suzanne covered, you know, great amount of work there around the strategic direction of what's happening in social care. But particularly around enhanced care, discharge to assess, any of those issues that Suzanne has raised. Have you got any questions before we wrap up? Let me just open